And go ahead, Cesar. Take it away. Thank you.
Yeah, thank you. Can you hear me?
Yes, we can hear you.
Okay, thank you. This will be my talk, Advancements and Challenges in Integrating Artificial Intelligence in Image Processing in a Clinical Setting. And firstly, I'm going to give you a bit of background of who I am. In these years, I started an internship at the Hospital de Sant Pau. I'm a biomedical engineer. I was studying biomedical engineering degree here in Barcelona, and I started in this hospital on automated quantification of esophagus damage in magnetic resonance after pulmonary pain ablation. I started here the year of COVID-19, and I made some segmentation, some analysis, etc. But this was really um, a short um, a short project because of the problems with accessing the hospitals these years. At the same time, I was doing my bachelor's thesis in biomedical engineering on application of artificial intelligence to make in silico predictions of thrombotic risk indices in the left atrial appendage of the heart. A bit of surrogates, a work that we presented in a workshop in the Mikai of that year from home. So the path or the field of artificial intelligence was inherent of my studies also. The next year, combining the two parts, the hospital part, more clinical part, and the artificial intelligence part, I did my master thesis here at Hospital de Sant Pau in coronary artery segmentation based on artificial intelligence methods. But the interesting part of my master thesis was not to develop a good AI algorithm to segment the coronary arteries, but how to integrate the AI algorithms in clinical workflows. So we made this mock-up and we started doing all this platform, how to we designed it. And the last years of my career, since 2021, from now, I am full-time working at the Dimension Lab here at Hospital de Sant Pau after my master's thesis, and I started doing my PhD part-time in a project in artificial intelligence, collaborating with them. And parallelly of my studies here at Hospital Sant Pau, they began with the Dimension Lab project. And the Dimension Lab project briefly started by buying some 3D printers to print the hearts of the patients with some pathologies or cardiovascular pathologies. This was like preliminary. And after the pandemic in 2020, it was like an inflection point here for the 3D part in the hospital, because we started doing personalized analysis of the COVID-19 patients with some interesting models, also with this face mask that you can see in the pictures. And Abdel, our boss, the cardiologist and also 3D designer, he did this design in collaboration with the HP company. And this design was printed more than 3 million times worldwide. So it was like an inflection point for the 3D part here, the 3D printing, 3D modeling, etc. And we collaborated also with some companies in this part that boosted us. And since 2 years ago or 3 years ago now, we started officially with the Dimension Lab, which is the official name of this whole project at the Hospital de Sant Pau. And basically, we are engineers there, and we form a team with the surgeons and the radiologists at the hospital for what? For these three different missions, which are providing healthcare, doing research, and also doing some teaching. And with the healthcare part of the dimension lab of the lab, I'm going to explain you what is the objective of this, not laboratory, but assistential or healthcare service in the hospital. The mission of the Dimension Lab is provide healthcare support through advanced surgical planning and designing and manufacturing custom-made medical devices with the use or not of 3D printing, but with the use of 3D modeling. And basically, we are contracted by the hospital with this mission. Since surgeries are evolving these years from a more open approach to a more robotic, autonomous approach, increasing the complexity. Also, it is increasing the necessity or the need for doing more pre-planning. The more preparative planning you do in the outside of the operating room, the more complex, sorry, the more robotic, the more pre-operative planning you need to do before going into the operating room. And for this, we are the department at the hospital in charge of this preparative planning in a transversal manner. And then I'm going to show you the different products that we do at the hospital, and then how to connect it with artificial intelligence that you are waiting to. And the first part of the process we do is acquiring the imaging studies or using the imaging studies. We work with computed tomography, we work with magnetic resonance, with three-dimensional echocardiography, and etc. Any 3D image modality that you can imagine. Also with some PET-CT images. And from this imaging part or these studies, we do these 4 different products, starting with a more simple product, which is the 3-dimensional anatomical model that can be virtual or 3D printed. Then with this 3D anatomical model, we simulate computationally the planning or the surgical plan of the doctor in the operating room, and we do it virtually. Then, if we want to convert this surgical plan from virtual to actually being into the operating room, we can design and manufacture surgical guides, and finally, some custom-made implants to be implanted into the actual patient. And the interesting part of the Dimension Lab is that we do all of these products personalized, meaning that they are for one patient and for one concrete or specific surgery. And we aim to provide solutions for specific surgical needs that cannot be fulfilled through standard methods or standard devices. And we are doing the design of all of these products here at the Dimension Lab, and the manufacture we are externalizing them by the moment. And from the image that I talked before, the first part is to segment the images. You may be familiar with this term, and it's basically determine the contour of the different anatomical structures of interest for the doctors. And with this, we construct the 3D anatomical models. In this case, this is a tumor, a leg tumor, a sarcoma, near the iliac artery and the veins. And there were some nerves around this structure. and we reconstructed this tumor from the CT image that you can see in the right, and with the contour superimposed to the image. The next part to the three-dimensional anatomical model is the advanced surgical planning. And with this advanced surgical planning, we perform the measurements of interest for the doctors. We can elaborate the plan that the doctors will do, for example, simulating some catheters in the case of hair surgeries or percutaneous surgeries. We can measure some areas, and also for the left atrial appendage closure, which is this case, or I don't know if this case, but we do some cases. We can analyze the accession point to the left atriums, for example. We can perform some thickness analysis to know which is the optimal entry point for these surgeries, etc. Some examples of these anatomical models and surgical virtual surgical planning are in orthopedic surgery, for example. As I said before, we are transversal service in the hospital, and we have open for many different services. This is an example. We are working with the hand and wrist team, with the hip team, the sarcomas team, the foot and ankle team, etc. You can see examples of the most simple anatomical models, and also for the virtual surgical planning of some applications. For example, in this case, we compute some planes for the cut of the bone in the case of some tumors. And this case is the virtual plan of a cutting guide. One of the parts in which we are more, or we can provide more value is the part of surgeries, the general surgeries, because in the case of cancer, each patient has a different cancer in general. And the approach for this is different depending on the pathology and depending on the specific patient. Yeah, and the cancer that this patient has. And there are some examples of liver cancer. This was a sarcoma in the chest of a patient, and this was the model, and the clinical the real translation, in which we edit this model and analyze how the ribs were below the sarcoma, and some examples for aorta and for lung nodules. Also, we collaborate with the gynecology team for example, endometriosis, for breast cancer, and also for uterus malformations. And this was an interesting case that we did in collaboration with a local hospital, in which a patient, a kid, born without the vagina, and we help with the 3D design of a silicone implant to be implanted into the patient. And it was patient specific exactly for this patient with some biocompatible silicone. And this case was so interesting, it appeared in the local news. Also, we collaborate with the neurosurgery team. And in this case, we have some interesting also 3D physical models. And we can do also tractography analysis, some reconstructions of strange cancers for neurosurgery. And also we do the comparison or the pre-surgery plan and the comparison with the post-surgery plan in the case of cephaleas. And the part in which we are more developed is cardiovascular, cardiac surgery, and vascular surgery. Because, as I said before, our director, which is Abdel Hakim Mustafa, is actually a cardiologist and a specialized in cardiac imaging. And for this part, we work on applications such as augmented reality, virtual reality, for sharing these anatomical models. Also, we have some nicer models, physical models in color, combining functional information with some anatomic information of the patient. This case, for example, this model combines the 4D flow imaging of the aorta for this aortic congenital disease with the anatomical contours of the aorta obtained from the CT. And this was really interesting to have it printed, the streamlines of the actual 4D flow of the patient. And in cardiology, we have many applications that we are sharing them with clinicians nowadays. The next part, next to the virtual anatomical planning, is how to integrate this anatomy or the advanced virtual planning, sorry, is how to integrate this virtual planning into the operating room. And this is done using surgical guides. There are two main examples, which are positioning guides and cutting guides. The first ones are for drilling a specific structure. For example, in this case, it's for reverse shoulder arthroplasty. And the cutting guides are used, for example, in the case of cancers, to perform the resection of this specific cancer or sarcoma, in the case of sarcomas. And each case requires a different cutting guide because each cancer is different, each patient is different, the bones are different, etc. And the approach that the clinician will follow are different. And we said that we are in the stage of research, but actually we are in production of these positioning guides, cutting guides, etc. But we are manufacturing them outside of the hospital because of some regulations. And finally, the last part is the design of custom-made implants, patient-specific. This is an example done with some external company. And as I said before, we can do this or design these custom-made implants, but we cannot manufacture in them at the hospital for the moment. And we aim to integrate these productions here at the hospital in a factory that we are building close to the design laboratory. This was the assistential part of the Dimension Lab, the core part, but we also have some teaching part, which is the Dimension Lab campus, in which we have the teaching mission or these three teaching missions. The first one is the clinical simulation, performed by designing simulators for clinicians. Also the training of clinical engineers here at the hospital. And lastly, the patients and family education. And the part of training clinical engineers, we signed some collaboration agreements with local universities. And each time we have like 10, for example, clinical engineers here at the hospital performing or doing rotations with us. Also for the part of the campus of the teaching, we promote in the Spanish Cardiac Imaging Society a 3D working group to promote the technology, the 3D technologies, and also the artificial intelligence. And we are doing some courses. This is the first course we've done for 3D printing, modeling. Also, we talk a lot about the artificial intelligence, etc. And the last part is the part that I said the first, which is the clinical simulators. In this case, we designed here at the hospital a simulator for mitral valve surgery for performing it minimally invasively. And a company here in Spain is manufacturing the long instruments to perform this repair minimally invasively. Nowadays, it is an open surgery, and we did here at the hospital, we designed the simulators for doing it, for replacing the alternative we were doing which was to do this training in pigs instead of the simulators. And as this was like more a research project, now I'm going to talk about the lab research in which the AI part is integrated. The research mission, sorry for this, is to integrate 4.0 technologies into the clinical workflow. The parts of simulation, like fluid simulation, mechanical simulation, additive manufacturing, augmented reality and virtual reality, big data and AI in the actual clinical workflows. And in the research part, we have two PhDs ongoing since 2 years ago, sorry. We have one patent of the product that I showed you before, and we are also researching two different medical devices. And also we collaborate with some research groups at the hospital and the research institute of the hospital, which are the cardiology research group, the radiology group, the three-dimensional platform that we created, and also the research groups such as neurology, neurosurgery, traumatology, etc. And after all this introduction, I am going to talk to you about my PhD and the whole project that we are doing in the hospital, in which I intend to create a framework, an artificial intelligence-based framework for prioritize and report patients with coronary artery disease in, I said, the radiology department, but in the cardiac imaging unit of the hospital. I'm doing it collaborating with Pompeu Fabra University of here. This professor that is in another university, not the autonomous university, and Abdel Hakim Mustafa, our director, the director of the Dimension Lab. Briefly, the coronary artery disease creates or is the cause of myocardial infarction because of the stenosis of the coronary vessels, which leads to plaque buildup that can rupture, create thrombosis, and the blood does not go to the cardiac muscle and create this angina or myocardial infarction. Here in the hospital, the CCT images analysis is done visually. The patients or the images are visually assessed, and they assess or analyze the stenosis degree and the location of this stenosis and the plaque. Also, they assess the plaque burden and the plaque composition, and also they visually detect other clinical findings. And this is a manual and visual process in the hospital. There are some automated solutions, but they are not usually used due to their unreliability, and that they are really different from solution to the other solution. This is a problem also because of the elevated reporting time for non-complex cases, in the sense that the patients without significant disease account for 65% of the patients in the last 5 years. And the problem here is that for these patients with low risk of of a problem, let's say, they spend a lot of time doing the clinical report because the workflow is really fragmented. It's not automatized here, and there are no patient prioritization, in the sense that these patients with more urgency may be positioned first in the working list of the radiologist, instead of the patients with a lower degrees of this disease. And for this, we say that non-complex cases have a lot of or an really elevated reporting time. For this, we aim to optimize this workflow, firstly creating the database for coronary artery disease identification, develop some coronary segmentation algorithms, and post-processing prioritization and reporting algorithms to be validated into a clinical setting for optimizing this non-optimal workflow that I explained. In this case, the first part was the creation of databases. I will be with later on. But for the coronary artery segmentation, this is really a challenge because segmenting coronary arteries is not a trivial task. There are some clinical and technical challenges, and clinically the morphological boundary is diffuse between the lumen of the coronary artery and the plaque. Also, there is a lack of annotated databases, and in general, technically talking, the balance between the foreground and the background is it's not unbalanced. The quantity of voxels in the background and the foreground of the images. And to create a database, annotating it manually, it's really time consuming. For coronary segmentations, the most popular architectures are UNet with the automatic configuration of the non-UNet. And we want to improve this segmentation, and we want to improve it. In general, the tubular segmentations, of which coronary arteries is an example of tubes and with a network structure. And our approach to improve the coronary artery segmentation is adding some constraints. For example, we explore adding auxiliary anatomy of the heart, but we are focusing on using some loss functions or topological priors to improve the segmentations. Some years ago, in 2017, some researchers create or design the central line dice, which is the CL dice, which is a loss function which aim to maintain connectivity by enforce the topology preservation. In 2021. And they aim to preserve the connectedness by creating or computing the skeleton of the prediction and the skeleton of the label of the ground truth. And instead of creating the loss function of the dice, they create the central line dice by computing topology precision and topology recolor sensitivity with the skeleton of the prediction and the foreground of the label, and the topology sensitivity with the skeleton of the label and the ground truth, the actual ground truth, instead of doing this only using the ground truth of the prediction, and doing a balance between these two parts. However, with this approach, there were some flaws. For example, it was not robust, and if they use some noisy annotations, and they boost the topological consistency at the expense of the segmentation accuracy, meaning that it was an approach um, with the skeleton of the prediction or the prediction, or they predicted a good skeleton instead of predicting a good coronary arteries in our application. And for this, we created the centerline cross entropy. As you know, the dice is or the subdice is a loss function used for the training of UNets or some neural networks. And from this, they created the centerline dice. And in our case, we are using the cross entropy loss function for creating the centerline cross entropy, or the centerline cross entropy loss function. And we created it to preserve the segmentation accuracy and also improve the topological coherence of the segmentation. Because for our application, the the cross entropy loss function work better by its own than the dice loss function. And with this approach, we had these conclusions, or these strong points, which were that segmentation had a better accuracy and also topology preservation in 2D and 3D datasets with respect to not using this centerline cross entropy. And also our main objective was to improve the segmentation accuracy with respect to the centerline dice. As I said before, the centerline dice predicted well the skeletons of the segmentations, but with our approach, not only we predicted better the skeletons of the prediction, but also we improved the segmentation accuracies. These were the quantitative examples in two-dimension retin datasets, in which you can see that not only the centerline dice score, but also the dice score were improved with respect to not using it. And also the dice score improved a lot compared to using the centerline dice. This is the centerline cross entropy. And also with a public dataset of three-dimensional coronary arteries, also we improve with the centerline cross entropy compared to the centerline dice, which did not improve at all, and with respect to not using it. And as you can see, the results were that segmentation using just the centerline dice notably lost the accuracy. And in our case, we increase both the topology consistency and also the accuracy across different datasets, retin datasets, two-dimensional ones, coronary arteries in 3 dimensions, etc. And the qualitative results also show these results. By using the centerline dice, there were some random problems in coronary arteries that you can see here, and when you try to compute the vessel centerline, and it was madness. However, our approach is not perfect, the centerline cross entropy, because there are some frequent errors in segmentation, especially the under segmentation of distal branches of the coronary arteries, the oversegmentation of distal branches in some little cases, the presence of external vessels segmented, for example, veins in some problems with contrast problems, and in some cases, these strange mistakes in segmentation in the main branches, as I showed before. And this is the most frequent error, the oversegmentation of coronary arteries in the distal branches, meaning that we have a lot of false positive predictions in this segmentation. And as you can see in this image, sorry for the low quality, there are some false positives which are actually coronary arteries, and this is not a problem of the approach that we are using, but this is a problem of the data set. And this is really a problem because the ground truth of ASOCA, which is the only public database for coronary artery segmentation, is that if this is the ground truth and this is the prediction, in this case, if we focus on this part, and if we perform a close-up of the ground truth and the prediction, you can see that the ground truth is actually not a good segmentation, and the prediction is actually a good segmentation. As I showed before in this toy example, the oversegmentation of distal branches, these false positive predictions, they are actually coronary arteries that are well segmented, but the numerical results don't say it. So this is a problem, and the problem maybe it's not a segmentation problem in this case, but it is a data problem. That's a problem. And for solving this problem with open source data, we are annotating a data set with cardiac computed tomography and angiography images, which are with and without stenosis, with and without disease, plaque, etc. And these images are validated by a cardiac clinical imaging expert because we aim to do a good segmentation, and since 4 years ago we explored some different methods, the NONINet, graphical networks, transformers. Last year we presented central line cross entropy, but the problem is not to find the best network, but it's finding the well data pool to use these state-of-the-art networks. And if we can perform a good segmentation of the coronary lumen, then the next steps are extract automatically the center lines and perform a stenosis analysis. A stenosis analysis divided by the coronary segment in which this stenosis is present, and also in the future the amount of plaque. And the final project will have the actual cases in the work list of the hospital, categorized by priority, depending on the GATRAT, which is a method used for computing the stenosis, or the severity of the patients, categorizing the severity of the patient, and also depending on the previous clinical information. And these cases will be prioritized because of this, or according to this. And also we will have some explainability of each case previously to validate the analysis or the report automatically done. This is work in progress, And the first part of this is having actually a good segmentation of these coronary arteries. And some years ago, we also wanted to use the segmented coronary arteries that we were segmenting with the non-UNET or the other methods, and to also show that that having a good segmentation, apart from the prioritization of the in the work list of the doctors, also served as input for computational fluid dynamic simulations by using this workflow, in this case, automatically segmenting it with performing not a lot of corrections of the segmentation, and then automatizing the part of the image generation, post-processing, etc., using patient-specific boundary conditions. We could perform this computational fluid dynamics, and also we visualize the results, showing that the automatic segmentation using these methods yielded some clinically possible results in terms of velocity and also wall shear stress. And the last part of this is the most complex part. I don't have it in a slide, sorry, which is the integration of all of this into the clinical workflows. And for this, we are developing a platform that I cannot show the pictures of the platform, but we are developing this, doing some mock-ups with in collaboration with the Department of Radiology, because we want to integrate all these solutions based on AI algorithms into our actual clinical workflows. For example, for my part, for segmentation, and then modeling, and finally the advanced planning of surgeries. We work with images. The first part, as I said before, is the segmentation. We are doing it manually by the moment, but also we are working on how to integrate some state-of-the-art models, for example, total segmentator, Monet Auto 3D Seg, etc., into our workflows. And this is, I think, the most complex part of this. We are doing this by the moment by generating the mock-ups of the platform, how will they be collaborating with the radiology department, but this is not that's an obvious task. And for seeing a more complex product such as this case prioritization in actual workflows of the radiology departments or the cardiac imaging departments, it will not be in few years, but I am sure that with this research, and also more especially this research being done actually in a hospital environment, it will be implemented in some years, I am sure. And this was the last part, and I will be glad to discuss this now in the questions and answers part. Thank you.
Thank you, Cesar. Let's give him a round of applause, a virtual round of applause.